始めましょう。Let me see if I can. Okay, so and these are some of the main aspects I would like to share today with you. First, to try to analyze some different aspects of moral distress in healthcare professionals, particularly in the light of the COVID-19 pandemic. First, I will start in general and then go to the pandemic. Then I want to explain and talk a bit about the term of collective moral resilience, which is a form to address or to manage this moral distress, and then to show how communities of practice can be crucial on fostering moral resilience for healthcare professionals. So first, I want to ask why moral distress is so important. Of course, for many reasons. On the one hand, we can think about the suffering of professionals in themselves, also because these sort of problems are increasing, seems that they are increasing year by year, and also because of the consequences or potential consequences that moral distress has, that can be for professionals, for institutions, and also for the care of patients, as we will see later. So let me start sharing the story of Dr. Lorna Breen. She was the head of the emergency department at the New York Presbyterian Allen Hospital in New York City. She, of course, dedicated her career of helping others, and she was treating patients with COVID-19, and she also contracted COVID-19. And she died by suicide after telling her family that she was reluctant to ask for help and for assistance for overwhelming work-related stress, because she feared that she would lose her medical license if she asked for help, or she could be excluded by her colleagues. This is, as the National Academy of Medicine said, is a tragical story, and is one of many because this is happening. And it's part of a big crisis that has been exacerbated by both by COVID-19 pandemic, but also by a pervasive culture of silence. Because normally healthcare professionals don't talk about our fragility. We don't talk about our weak points, about our problems to face the daily problems that we find. So moral distress, moral distress was originally defined by Jenton in 1984 as the psychological distress of being in a situation in which the person is constrained from acting on the correct way because of the presence of different institutional or external constraints. In fact, after this first definition, now we know that there are not only institutional or external barriers or constraints, but also internal ones. We have to differentiate also moral dilemmas than moral distress. In moral dilemmas, the person really don't know which one is the correct course of action. What is the correct thing to do? That's why it's a dilemma. And it can cause moral suffering more generally. But when we talk about moral distress, the professionals really know what is the correct thing to do, what they should do. But the problem is that they cannot do in that way because of these constraints. So this is a image that shows these internal and external constraints. In case of internal constraints or personal, we have the individual character. Obviously, each person has different ways to deal with adversities. We have ethical competence. We can understand as ethical competence the ability to engage in ethical reasoning, knowledge about codes of ethics. Some research have found that as much as professionals have more ethical competence, they cope better with moral distress, have less moral distress. and is different in case of moral sensitivity. And I'm glad to see Professor Onishi from Conan Women's University joining us today, because she's an expert on moral distress. She has been addressing and researching about Japanese psychiatrist nurses' moral distress for years. And in one of her studies, she addressed precisely this aspect, the relationship between moral sensitivity and moral distress in two different populations of psychiatric nurses in Finland and Japan. And they found that it was positively correlated, which means that as more moral sensitivity the nurses have, more moral distress they develop. So it doesn't mean that having moral sensitivity is something bad, just that we need to support them better to avoid or to manage moral distress. Then level of assertiveness, of course, the way how we communicate with others can be a constraint. Religious values, which include a lot of different religious beliefs, and personal qualities like the experience of the person, the perceived powerlessness that the person have, etc. In the external constraints, we can have hospital policies or policies in general, national policies that can be a constraint. The interest of the patient's family sometimes can be in disagreement with the interest of the person or with the interest of the professionals for treating the patient. Hierarchy in the healthcare system, especially sometimes between different professions like nurses and doctors, excessive workload, and poor communication within the team. And there are some other factors that are a combination of some internal and external constraints, like, for example, conflict with other healthcare providers, in which we can have maybe individual character involved, but also the hierarchy within the system, or controversial end-of-life decisions, which also involve or can involve religious values and also, for instance, policies. So let me share in brief an example from my own work. At that time, I was working in emergency room in the hospital in Tenerife. This emergency room has an observation ward, which was prepared to take care of 12 patients, but at that time we had about 20. I had this day a 75 years old patient who needed a non-invasive mechanical ventilation system to breathe, which is a really hard treatment because the person needs to have a mask and it's quite difficult to be adapted to the machine. So he was nervous, continuously removing the mask with a lot of anxiety. And in this room, the visit of the family was only allowed for 30 minutes. When his son came in, he started feeling some relief, feeling better, having more cooperation, breathing better. So I talked to my supervisor to tell him that I wanted this son, if possible, to stay there longer because it seems that has a positive effect in the treatment of the patient. And the response was no, because it's the hospital policy. And the time for visit need to be the same for all the patients because for quality reasons, for them, the other patients not have complaints. So I felt really frustrated because I knew that sooner or later this patient would need to have maybe physical restraints to avoid removing the mask, and it will take longer for him to recover. So when a person have to act against their own values, the result is a long-lasting moral residue, which can damage the mental health of the professional in itself. So moral residue is the result of moral distress when we have compromised ourselves, threatening or betraying deeply held and cherished beliefs and values. And moral distress has been associated also with negative consequences, as emotional distress, staff turnover, or occupational burnout. This is a diagram which I took from this article, which is in the screen. It was an article performed by different associations of critical care doctors and nurses in the US. to somehow give visibility about the burnout syndrome. In the slide, you can see on the top that we have these personal characteristics or internal factors I mentioned before. On the other side, the organizational or external factors. The first arrows let us, if we have these factors, people can develop moral distress or other related syndromes as perceived delivery of inappropriate care, compassion fatigue, for instance. When people experience this, the next step, if this situation somehow is maintained longer, people can develop burnout syndrome. The other possibility, people also can have these personal factors or the organizational factors and have directly burnout syndrome from experiencing in a continuous way these kind of barriers. Once the person have burnout syndrome, which is, as I said, or can be a result of moral distress, they can experience post-traumatic stress disorder and other psychological symptoms. Also, burnout syndrome increase the rate of job turnover and, importantly, decrease the quality of care and the patient satisfaction. So, what happened in the pandemic? These situations are happening on a normal basis. We have a lot of professionals facing and struggling with all of these stressing situation because the care work involve an important emotional impact on ordinary conditions. So if we add the COVID-19 pandemic, things just can be worse. So, of course, there are many aspects involved in the pandemic. This is just a kind of summary. The pandemic has been a kind of moral distress trigger for healthcare professionals because has somehow led professionals to have to face situations that they normally don't have to do on a normal basis in many places. So I will address one by one these different aspects. One of the reasons why the COVID pandemic is this moral distressing trigger is because of the necessity to prioritize scarce resources, as we have seen. The other reason is because of the incapacity of healthcare professionals to provide the best standard of care as they would like to do. And other is the lack of personal protective equipment, which have led healthcare workers to have to deal with unacceptable conditions at work. Let's start with the first one. I think I would like to do this clarification. When we talk about prioritizing scarce resources, there are different aspects involved. First of all, in general, in the healthcare practice, we always have to think in terms of adequacy. We have to try to have a good relationship between the aims that we are pursuing and the means that we are using. In case of end-of-life decision-making, mainly in intensive care unit, but also in other contexts, when the healthcare professionals perceive some kind of disproportion between these goals that they want for their patient and the means that they need to use, they can withhold or withdraw treatment. When we are talking about withholding treatment, we are saying that some diagnostic or therapeutic procedures will be restricted. For instance, deciding not to intubate a patient if he or she gets worse. In case of withdrawing, it means to cancel some type of diagnostic or therapeutic measure. For instance, okay, the patient is intubated already, but we are going to decide to stop the mechanical ventilation and remove the tube. In fact, in general, healthcare professionals tend to think that not taking any action is less, let's say, is ethically less controversial than doing actively some actions. But in fact, it seems like withdrawing a treatment can be better in the sense that sometimes when doctors have to make this decision making, we don't have 100% of evidence about what is going to happen. So if we have some patient with some very few opportunities to recovery, but somehow the team said, okay, let's try to have this 3% of possibility. Okay, let's try, let's intubate the patient, because then we know that if we can see that it's a futile treatment, we can remove it. So let's give the patient the opportunity. We can discuss more about that later if you want. In fact, Professor Tanaka and Professor Kodama have addressed the issue about withdrawing dialysis treatment in Japan and the difficulties that the healthcare professionals can find. Of course, when we do that, what we are trying to avoid is the therapeutic or unreasonable obstinacy when we provide some treatments. Then the second aspect involved is the allocation of scarce medical resources. We have had in this pandemic many discussions and struggles in different societies of bioethics about which criteria are better to use for allocation. In this case, when we talk about allocation, the decision is not focused on the potential benefit of the treatment for the patient, because we have 4 or 5 or 6 patients and all of them will have some benefit for this treatment. The problem is that we only have one treatment, let's say one ventilator. So we need to decide criteria to establish which person would be the recipient of this ventilator. And in this sense, of course, this kind of decision making are always dramatical, because we don't want to select people to decide who is going to have a treatment, because this implies that we are deciding who is not going to have access. In this context, also the previous withholding and withdrawing treatment, which normally is based on the patient, is affected by this scarcity. Because when we have limited beds, let's say in intensive care unit, if we don't have free beds and doctors are facing the decision of withdrawing a treatment, probably these decisions would take less time and they would do shorter than normal conditions, because they know that these are scarce resources. And the third is the emergency triage. Triage is understood as the assignment of degrees of urgency to decide the order of treatment in a large number of patients. So in the context of the pandemic, doctors are relieved of having to make these difficult decisions alone when they have explicit criteria, when they have, let's say, a list of criteria that help them to make these decisions. Also, maybe patients and their families also can have some benefit from having clear criteria, transparent and public, about which criteria are using, for instance, to admit a patient in an intensive care unit in this context of the pandemic. On the contrary, when we have somehow controversy and we don't have a moral consensus in the community about what triage criteria are most appropriate, there are a proliferation of opinions and recommendations from different societies, and this only increases the moral distress of healthcare professionals who need to make these decisions in the moment. For instance, I will put now some examples from Spain. In Spain, at the beginning of the pandemic, the Society of Critical Care Medicine provided some criteria to decide this triage in intensive care unit. And somehow soon after that, the National Committee of Bioethics disagreed with some of these criteria. So started having discussion about that. The problem is that in this disagreement, they didn't provide clear criteria for healthcare professionals. So this increased the confusion and the problems that doctors at the bedside have to face. Also, of course, not all the criteria relieve doctors. Sometimes the criteria for this triage only increase the moral distress. This was a kind of scandal that happened in Spain at the beginning of the pandemic. In the care home, we had in some community in Madrid, the care homes received instructions for the authorities to not transfer elder patients institutionalized there if they have COVID-19, not transfer these patients to the hospital. So I don't want to imagine the moral distress that healthcare professionals working there had to face, because they couldn't do anything for these patients, and these patients just died there in the home care without any treatment. So yeah, sometimes the criteria create more moral distress, of course. The second aspect that I wanted to address about this triggering moral distress is somehow the COVID-19 pandemic has been a kind of threat to family-centered care in intensive care unit and in general in hospitals. At the beginning of the pandemic, all the visits were cancelled in the hospitals to try to avoid the spread of the COVID-19. This implies that the patients were facing this situation completely alone, yes, with the healthcare professionals working there. And also, the families only could receive information by phone exclusively, including communicating bad news. And all of this has a tremendously demoralizing impact. It's a demoralizing experience with a lot of emotional impact in both in the family and also in the professionals doing that. Last week, somehow the healthcare professionals in Spain were awarded with a kind of national recognition. And in the speech of some of them, I will read her words. She said, "A woman had been calling me all afternoon to see how her husband was doing. At 9 o'clock at night, I called her to tell her that they were going to transfer him to other center because we were saturated. A minute later, the staff informed me that the transfer was being cancelled because he was dying, and I had to call her again. I have had to do that other times, but that night I cried a lot," she said. So this is the kind of impact that these news have. And the third aspect I wanted to mention is this was addressed in the BMG blog on the title of The Duty to Treat, Where Do the Limits Lie? So doctors and nurses are dying. This was posted in May of this year because of the combination of a novel virus without treatment. In fact, still now, the WHO last week provided the results of a big trial, and the conclusion was that we still don't have an effective treatment to really decrease the mortality rate of COVID-19. And also because of the inadequate supplies of personal protective equipment. All of this is somehow putting frontline healthcare workers at risk of harm. So the questions arising is when the work-based risk become unacceptable. And if there is a point when healthcare professionals have a kind of right to not treat seriously ill patients if their safety is not ensured. So in case of rescue teams, we have a clear idea about that. All the people know that the safety of the rescuer is the first. We cannot try to save other person if the rescue security is not ensured, because we will have 2 casualties instead of 1. But when we are in a consultation or in a hospital, the situation changes a bit. So I remember the story of a general practitioner in Spain who was working in a primary care center in a rural area, and he was attending around 50 or 60 patients per day with COVID-19 symptoms and without adequate personal protective equipment. So after that, he contracted COVID-19 and he died. But what can he do? I mean, it's not possible for a doctor in this position just close the doors of his consultation and say, sorry, I cannot attend any of you. Because in case of COVID-19, the perception of the risk is different than in case of a fire when we are fighting, when we are going to rescue someone who is fighting with the fire. So this is a point that I think we really need to address for the next problems that we are gonna face. Well, as the result of all of these new problems with the COVID-19, there are many studies showing the impact, the psychological impact of the COVID-19 in the mental health of healthcare professionals. These are just summary. In Italy, for instance, 49% have post-traumatic stress. In China, about 50% of healthcare professionals have depression and 72% distress. In Ecuador, more than 90% of medical and nursing professionals have moderate to severe burnout syndrome. And also some studies show that medical and nursing students are experiencing stress and anxiety during this pandemic. So in the second part of this lecture, I want to focus on what we can do, how to deal with all of this situation. Of course, to avoid moral distress, we have to work on fixing the organizational factors involved. The organizations need to address or try to fix, if possible, all of these organizational or external problems that are triggering. For instance, providing enough personal protective equipment and don't accepting overwork. But also, it's important to find the way how to cope with moral distress. In this sense, these are two ways to do. We have moral courage and moral resilience. In case of moral courage, is defined as the capacity to overcome fear and stand up for the core values, the willingness to speak out and do the correct thing in the face of forces that would lead a person to act in some other way. Is to prioritize the values, the ethical values, over the forces that want to make the person act in other way. So moral courage is a way to face moral distress in the moment. Is the way how the person can respond when she or he is facing the problem. And of course, people sometimes who act with moral courage can be fired or can be at risk of fire because they are somehow facing the institutional policy many times. For instance, in the example I shared at the beginning about my own experience, a response with moral courage probably could be something like telling my supervisor, I'm afraid, but I'm not gonna tell this person to leave the room, the observation room, because his presence is benefiting my patient. So if you want, you can invite him to go out, but I'm not gonna do that. But at that time, I was a novice and I couldn't respond like that. Then on the other side, we have moral resilience, which is defined as the capacity to sustain or restore integrity in response to moral complexity, confusion, distress, or setbacks. So moral resilience somehow comes after we have faced this moral distressing situation to restore ourselves, to restore the healthcare professionals' integrity. Of course, both are related, and as far as people, healthcare professionals, develop moral resilience, they will have a better capacity as moral courage. I will focus on moral resilience. In the last year, somehow we have had a lot of research about moral resilience, especially in nursing studies, but also in medicine too. And For instance, in the American Nurse Association, we can find some different strategies to increase or foster moral resilience. These include fostering self-awareness, develop self-regulation capacities, or ethical competence. The main problem that my colleagues at Cumming School of Medicine in Alberta, Canada, and I have found is that this concept or this idea of moral resilience has focused too much on individual aspects, only on individual aspects. So we believe that there is a necessity to turn this concept of moral resilience toward a more collective concept. Why? Well, first, because resilience is a capacity that requires a supporting environment to make it possible. Look, in the article I mentioned at the beginning about the burnout, which was provided by different critical care societies, the authors say, and I will read, healthcare professionals should consider taking individual accountability for maintaining their own emotional and physical health and for building resiliency. So it seems that all the responsibility on deciding to be resilient or not is on the individual. Really? I mean, remember the story that I shared about Dr. Lorna Breen in New York City, who committed suicide. Is she the responsible for not being enough resilient? Is not the institution the responsible for providing support for all the staff to help them to navigate moral distress, compassion fatigue, and burnout? In this sense, many authors, and me too, we really believe that resilience is not just a personal choice. It needs collective support from the society and from the different institutions to be developed, in this case for healthcare organizations. And resilience must be fostered due to the enormous emotional burden of care, as well as because of the responsibility and risk that it entails. And of course, also in agreement with Professor Onishi, again, in one of her papers, she mentioned that, of course, recognizing all the negative aspects that moral distress have, we also can consider some positive aspects because it can lead professionals to have some motivation to be moral agents and also to want to help others to address better and to navigate these distressing situations. But we need to be careful with the concept of resilience because resilience cannot be promoted as a mechanism to cope with unacceptable or dangerous working conditions, as overwhelming work and lack of personal protective equipment. Is not the case to promote moral resilience in healthcare professionals, just like to tell them, you can cope now with whatever you have to do because you are a resilient nurse or resilient doctor. So I'm not gonna try to solve the problems in the institution because now you are resilient, you can do that. This is not what we should do. For example, Squeers have a lovely metaphor. He said, if, for example, physicians were sailing on a leaking boat, healthcare institutions commonly appear, suggesting that the physicians bail more quickly instead of helping them plug holes. Of course, the institution needs to fix the problems at the same time than promoting resilience. So due to all these problems with this concept, my colleagues and I have proposed recently the term of collective moral resilience. And we have defined, this is a paper that is still under review, we are defining as a shared capacity that arises in a group with mutual trust and connectedness through the process of sharing ethical challenging situations, thinking together about the challenges, and dialogue to sustain or restore moral integrity in response to moral suffering. Of course, this is a term under construction and it will need more feedback to make it stronger. This is a diagram to show how we think it can be possible to foster this collective moral resilience. We have found that communities of practice has the potential to do that. I will explain later in detail what is a community of practice. But in these communities of practice, which are groups of people, of professionals, we can create mutual trust. At the beginning, to start, we need to have some mutual trust to start exposing ourselves and talking about these ethical problems. But also through the interaction with our colleagues, we can create this mutual trust and connectedness. Because when we realize and recognize that the other is facing similar problems than I am, this increases the connectedness between the peers. And on doing that, it's possible to create a shared capacity to navigate these problems collectively, more like a team. The main goal of these communities of practice on this purpose would be to build more collective moral resilience and to restore the integrity. And the tools that we are going, or that we can use to do that, are dialogue and thinking together. The process of thinking together has been theorized and conceptualized by PIPCO and colleagues as a transpersonal knowing process, which is a good way of sharing tacit knowledge. The idea is that the knowledge is redeveloped rather than literally transferred from one person to the other. It's redeveloped together. So what is a community of practice? Well, in the last 30 years, this concept has appeared and evolved mainly in the field of education and business, and more recently in healthcare. A community of practice is a group of people who share a common concern or set of problems, a common interest in a topic related to the practice, and who come together to learn how to do it better. So the main focus of communities of practice is on sharing the best available practices and creating new knowledge to advance a domain of the professional performance, of the professional work. Somehow all communities of practice share these three different dimensions. One is the domain. The domain is the necessity of shared learning. What is the main topic that the community of practice is going to address? What is the problem? What we want to talk about to solve or to fix? Then we have the community, and the community can be different. We can consider community of practice, or we can have a community of practice in the teamwork, for instance, in the teamwork working in oncology or working in intensive care unit, or we can have a community more broad with different professionals working in different hospitals among the country or among the city. Or we can have also virtual communities of practice, people sharing this interest on different places. And the other aspect is the practice, because it's the specific focus around which the community is developed and want to maintain. So in case of healthcare settings, we can say that communities of practice are intentional, because always communities of practice need to be intentional. People want to be there, people want to join these groups, are spaces to promote the exchange of experiences that arise in clinical practice. In the literature, we can see that we have communities of practice in healthcare in the two first points that I highlight there. One reason why we have communities of practice is to share clinical information about relevant problems. For instance, we have seen in this COVID-19 pandemic kind of spontaneous community of practice, global community of practice, with doctors and nurses sharing what they were doing to manage COVID-19 patients. For instance, doctors in Italy share, we are using this mask through the social media, or we are putting the patients in prone position, because this is the practice, this kind of tacit knowledge that communities of practice address. There is no other way to learn this kind of activities or process, just become from the practice. The other reason why we have communities of practice normally in healthcare settings is because of some urgent clinical problem. For instance, if we have a patient who has a kind of multidimensional problem, a group of different professionals can join together to address how to solve or how to try to find the best treatment for this patient. And my colleagues and I have proposed in a previous paper that also it would be necessary or interesting to have communities of practice in healthcare settings to discuss the ethical, social, psychological, and emotional side of caring for patients and families, because these discussions in groups of peers can be a good source of practical knowledge. And next. So why we believe that communities of practice can do that, can foster moral resilience? Well, our hypothesis is that communities of practice offer this opportunity for social support from the peers, because the peers really understand specific work-related factors, and they can somehow navigate together and support each other. Of course, communities of practice need to have navigation and need to have someone leading or guiding the group to provide this support. These are some experiences in some different research papers that show we don't have, as I mentioned, still communities of practice, as far as I know. Maybe now a new paper is appearing, but I don't know yet. Communities of practice addressing these ethical problems. But we have other research that suggests that this support from peers can increase the way how healthcare professionals perform their work. For instance, the first one mentioned about how healthcare professionals in the pandemic who report strong social support network have less degree of stress and anxiety and better self-efficacy at work. Then we have SWOT rounds, which is a kind of big center that provides a different space for healthcare professionals to share these experiences about the impact of care for patients and families. And some studies about these round centers, these rounds, have shown that when the healthcare professionals really share experiences with their peers, they really know each other better, and this can create better trust and empathy within the team, increasing the connection and the performance of the work. And then also there are studies, randomized controlled trials, addressing some intervention with discussion groups, also to address the same problems, show that reducing that these groups reduce the stress, including depersonalization, which is one of the dimensions of burnout. And also this is maintained on long term, even 12 months after the intervention. So I will finish in just two more aspects to consider. I want to insist on the role of organization on responding to moral distress is somehow a responsibility of organizations to provide these kind of opportunities for healthcare professionals to navigate these problems, and meantime, fix the organizational factors that trigger it. On doing that, responding to moral distress, the organizations also have the opportunity to build a more ethical practice environment. And then in the discussion, we can discuss what can be ethical practice environment, if you want. And also, we have to focus on education. Establishing a culture of acknowledging and responding to moral distress in the early stage of the career can prevent moral distress and moral residue, and also can increase the moral courage and collective moral resilience of students. And just to finish, some remarks or next questions, because each point led to new questions all the time. Healthcare organizations, as I already mentioned, have the responsibility to address the multidimensional aspects of moral distress. Communities of practice can offer an opportunity to engage with the peers to navigate the emotional side of care work through this process of thinking together. And it's necessary to include the management of moral distress in the curriculum and the profession in the early stage, but also in the training. And of course, more research is required, both theoretical and empirical, and I will be happy if I can have the opportunity to continue doing this research. So thank you so much for your attention. This is my email. You can send me an email to share any documents, paper, whatever you want, or continue the discussion. Thank you so much, and arigatou gozaimasu.